Good afternoon, morning, and evening all. It is wonderful to welcome you to the first webinar we are coordinating at Young Leaders for Health, addressing COVID-19 and mental health, impacts, lessons, and opportunities. I'll give a few seconds as people are joining and take the time to introduce myself. My name is Claudia Batz, and I have a background in public health with a particular interest in NCDs, nutrition, and mental health. My engagement with Young Leaders for Health started in 2018 when I myself participated in one of the organization's initiatives, the Social Entrepreneurship Challenge. I then worked on the organizing committee for the 2019 edition with peers and confidently can say that we have a network of immensely dedicated young professionals engaged in both planning and joining our initiatives. I currently engage as a team member supporting wider organizational initiatives alongside my role as a Policy and Education Coordinator at the World Obesity Federation. Over the coming weeks, through a series of bi-weekly webinars, we aim to reveal practical solutions to the mental health challenges we are all grappling with, including new means of mental health care delivery. There is no doubt that the COVID-19 pandemic has entrenched and exacerbated inequalities in mental health for our generation, and we endeavour to comprehend the impacts of COVID-19 on mental health, lessons learned, and way to improve and build back better to improve health for all, hence protecting future generations. Today's session will focus on psychosocial considerations for vulnerable populations. Next slide, please. Before we delve into presentations by our esteemed selection of speakers and panelists, I want to share a few housekeeping rules. We ask you to kindly mute your microphones if you are not speaking. A Q&A function will also be available to post questions and to post comments and ask questions. There will also be a chance to ask questions addressing specific speakers, and we shall attempt to address these in the panel discussion at the end of the webinar. The recording of the slides will also be circulated after the session, and we have two Young Leaders for Health hashtags that you can feel free to use for live tweeting or after. YLH webinars and YLH SDGs. Next slide, please. So I really want to just start off by outlining our mission and vision at Young Leaders for Health and how this fits into the series we are coordinating. At Young Leaders for Health, our main aim is to nurture the next generation of leaders in public and global health. We intended to bring together students and young professionals this summer for our annual Social Entrepreneurship Challenge that I alluded to before. And this is an event within a unique program that gives participants the opportunity to partake in interactive keynotes, workshops, by leading global health practitioners where they sort of strengthen their understanding and of the depth and complexity of the theme that's being tackled each year. This year, we were supposed to meet in Berlin to work on project ideas to find sustainable solutions in the field of mental health. And this series came to life after it was postponed. Our vision at Young Leaders for Health is a healthy, inclusive, equitable, and accountable society, free of structural discrimination that peacefully coexists with nature. And by equipping global health enthusiasts such as you with the latest impact of COVID-19 on mental health and how to address it, we hope to empower you to act as change makers. We'll address the impacts of and psychosocial considerations for vulnerable populations, lessons learned from the pandemic, and opportunities for digital mental health. Next slide, please. To put into context, I want to start by showing this Johns Hopkins Center dashboard that many of you might be familiar with. It receives approximately more than 1 billion hits every day, and it's perhaps the most reliable source to see COVID-19 cases globally. At the beginning of April, we had just 1 million confirmed cases. But now today, as of the 9th of July, we've passed 12 million cases, confirmed cases of coronavirus. The dashboard shows both cumulative cases and global deaths. Previously, individuals that recovered were not typically reported, but this is now a feature, as you can see on the right. And the US, Brazil, and India are amongst the countries affected the most by COVID-19. The pandemic has really revealed, next slide, please. The pandemic has really revealed the particular vulnerabilities of those with underlying conditions such as cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes and obesity. Nevertheless, mental health is increasingly stigmatized, and its prevention and control is as crucial as addressing other NCDs that are proven to be a major risk factor for patients with COVID-19. We have all been exposed to restrictive measures such as lockdowns, social distancing, and travel restrictions to reduce the impact and spread of the infection, but the consequences on people with NCDs is often more severe by limiting their ability to access preventative or health promotion services, and equally to their ability to secure healthy, nutritious food. And chronic conditions can also worsen when we are exposed to stressful environments and situations such as insecure economic situations, restrictions, and changes in normal health behaviors. So hearing from people living with NCDs is equally as important, and something that I personally am very passionate about. But today we'll really I want to allude to the point that, studies have predicted that if infection with SARS-CoV-2 follows a similar course to other coronaviruses, most patients should recover without mental illness, but we should be aware of the possibility of depression, anxiety, fatigue, and other conditions such as post-traumatic stress disorder actually becoming more prevalent in the long term. I have joined webinars that have addressed other NCDs and COVID-19, but will focus more on mental health in detail and the role of equity and gender in addressing mental health conditions. And there I've posed a question that you can consider, and I'd be interested to hear our audience's thoughts on the question. But I believe that gender is a key determinant of health, and really this pandemic has really highlighted and the chronic health inequities and social fragility of the society we are living in. Next slide, please. Here you can see the agenda for the day. So we'll start off with an overview of mental distress during the COVID-19 pandemic. And before we move on to sessions covering mental health support for refugee women, women leadership in global health, inequalities, and covering topics such as the Black Lives Matter movement and the implications in the US, before we lead on to a panel discussion and summary and closing remarks. Next slide, please. We are delighted to have our speakers with us today. So we have Roopa Dhatt, it's an Executive Director from Women in Global Health. We have Priscilla Dudhia, Policy Officer at Women for Refugee Women. Aiysha Malik from the World Health Organization in Geneva, and our fellow Young Leaders for Health Organizing Committee members, Carley and Alex. Next slide, please. It is now my pleasure to introduce Aiysha Malik. Aiysha Malik is a technical officer in the Department of Mental Health and Substance Abuse at the World Health Organization headquarters in Geneva, and is the lead for workplace mental health. Her work also includes psychological interventions for young adolescents and their caregivers in humanitarian settings, and technical support for World Health Organization's work on suicide prevention. Her attention has now turned to responding to the mental health and psychosocial needs generated by the current emergency response to COVID-19.
Thanks a lot. Very, very pleased to be here with all of you. I've been asked to maybe start with clarifying what we mean by mental health. So, and this might be, many of you might come from very different backgrounds and different health backgrounds. So I'll start with that. So when we think about mental health, we may think of things like common mental health disorders, such as anxiety and depression, which are clinical states, clinical mood states, which affect how we feel, how we think, how we behave. It can affect our physical bodies and can have a debilitating impact on our everyday functioning, such as with how we get on in relationships or how we might participate in society. But mental health can also include severe mental health conditions as well, such as schizophrenia and bipolar disorder, things which affect almost 65 million people in the world, and which are often subject to human rights violations. But you might have also heard many times that mental health exists on a spectrum, and this is quite important for us to think about here with COVID-19 in particular, because as part of this spectrum are symptoms of psychological distress. So this is without necessarily having a mental health diagnosis per se, but experiencing distress which is not pleasant and not comfortable and reflects symptoms of, say, anxiety and depression. And of course, mental health also encompasses good mental health as well, where we experience well-being, we can cope with stresses in life, we can work productively, we can participate in society. And that's the state that we hope to predominantly be in. And ultimately, if many people and their families are affected by mental health and struggle to function, then societies will struggle as well. And this is important, and this is why mental health has been conceived as a crucial aspect of the COVID-19 response and recovery for societies. So here, with setting the scene on this slide, prior to COVID-19, mental health was already an area of concern and burden worldwide, coupled with also being a field of health that has been historically, traditionally underinvested in. Yet the data speaks for itself here. For example, almost 264 million people in the world experience depression. And the global economy loses almost $1 trillion per year due to common mental health disorders, predominantly through lost productivity. Young people are very important in the field of mental health. Almost 10 to 20% experience difficulties with their mental health, even when they don't have access to services. And almost half of all mental health conditions in adulthood begin by the age of 14. And shockingly, suicide is the second leading cause of death in young people aged 15 to 29 years old. We know that in emergency settings affected by conflict, that 1 in 5 people live with a mental health condition. People with severe mental health conditions are estimated to die almost 10 to 20 years earlier than expected compared to the general population. And with all this in mind about the suffering of people with mental health, fewer than half of countries who have a mental health policy have one that's aligned with human rights conventions. And in low and middle income countries, but also in high income countries as well, there is a gap in the availability of services for people living with mental health conditions. And alongside this, there is a gap in the workforce, so the availability of people who can work in mental health worldwide. Next slide, please. Thank you. Oh, it appears to have skipped a slide. Could you possibly go back one? Oh, no, there is a slide missing. So that's fine. I'm just going to continue. We can keep it on that page for now. So in terms of mental health and the impact of COVID-19, having presented the, I suppose, before picture to you, we can expect that the after picture may worsen and decline as a result of COVID-19. And why might this be? Well, mental health can be impacted at any point in time by any combination of stressors at the societal, economic, relational, biological, and psychological levels. And adversity is a well-known risk factor for mental health or poor mental health. And by now you'll be very familiar with the adversities that COVID-19 has brought, including anxiety and fear of the infection itself and the health consequences, but also stresses from the necessary measures to prevent its spread. And this has been a huge alteration to many aspects of our lives, from working to education to social connections, and also to aspirations and uncertainty about the future. So if we go back to maybe thinking about the spectrum of mental health, we can expect that, for example, people who might have previously coped very well might be less able to cope because of experiencing multiple stresses as a result of this pandemic, or people who had some experience of anxiety and distress might experience an increase in the duration and intensity of these symptoms and may experience a mental health condition. And people living with mental health conditions may experience a worsening of their symptoms or relapses. And whilst it is by no means to say that it's not serious, it is expected to see an increase in distress as a result of such adversity as caused by COVID-19. And this is what has been seen in other contexts of emergency settings and other contexts where there have been infectious disease outbreaks. Very unfortunately, though, some of the methods to cope with these stresses can also worsen mental health outcomes. So, for example, there's been some indication from unpublished data that there's been increases in alcohol or substance use during COVID-19. And very concerning and an area of great focus for UN agencies such as ILO, who are in the midst of a global summit on this right now, is the future of work. There's been a huge impact on livelihoods and the economy, and this is very concerning as previous economic crises have been associated with death by suicide and related to substance use. So it paints a very challenging picture for mental health during this time. And one of the big issues is, of course, access to services and the fact that there's been a disruption to the delivery of services as a result. So in spite of this greater need, services have not been as easily accessible, and that's predominantly because of measures put in place to prevent infection, but also through loss of staff who might fall ill, or the redirection of services such as beds in mental health wards to COVID wards. And there's been a lot of innovation in order to address this. Earlier we heard the mention of digital health. So yes, many services have switched to remote delivery of mental health care, making use of digital self-help or digital mental health services or emergency telephone lines, for example. And these are effective, they're very scalable, which is important, but they're not well accessible to all members of the population. So for example, people who might be illiterate, people who might not have access to telecommunications, or even older adults, or some older adults. So there's still a lot of innovation to think about when it comes to particular members of the population, how we can ensure that they are able to receive the services that they can. And there are innovations to reach these groups ongoing at the moment, which are being considered. Obviously, key populations who will or are more likely to experience distress during COVID-19 due to their vulnerability to adverse risk factors include frontline health workers. It includes older adults and people living with underlying health conditions, young people, women, and people living in humanitarian and conflict settings. I think for frontline health workers and first responders and people working in long-term care homes who are paramount for the response to COVID are themselves at enormous risk of stress at the moment, from the infection itself, but also the undue pressures that are placed on them at work, the ethical dilemmas that they're facing at work, and witnessing of higher suffering and mortality than they might be used to as part of work. Not to mention the fact that there is stigmatization and harassment and violence against health workers. In older adults and people living with pre-existing conditions, demographically, this is a group who is at risk of serious health consequences from COVID-19. So fear and terror is part of this equation. And some, including those older adults who might be living with cognitive impairments, might have difficulty with accessing the advice that's being provided, might be at bigger risk of isolation. And we know that isolation is a huge risk factor for older adults. For young people, we think the full spectrum of young people, from children to adolescents who might be living at home and might still be in education, have faced disruptions to that education at a time that's very critical for their development and creates a lot of uncertainty for what might come next, but also might be vulnerable to domestic violence and abuse and big child protection concerns as well that are occurring under lockdown measures. Women are a group who have been identified as a group who are experiencing multiple stresses. And I think we'll hear more about this later on. So I'll just touch on the fact that, you know, there's an increased burden with additional caregiving duties, especially for women who are also still working at the same time. And there is research for health workers which shows that female health workers are experiencing higher levels of symptoms of anxiety and depression compared to other health workers. And with people living in humanitarian conditions, as I've said, 1 in 5 people in those settings are experiencing a mental health condition already. And COVID-19 may worsen this. And this is all in the context of already having very limited access to quality mental health services. So in terms of, that's just an overview. In terms of WHO's role so far, it's probably best conceptualized at 3 levels. So the first level here is around leadership. And the leadership roles that we have taken as part of this response is first through the interagency coordination, where WHO is one of the co-chairs for the interagency standing committee's reference group on mental health and psychosocial support. So this is a global coordination mechanism of almost 60 UN and non-UN agencies who are working in emergencies. And through that, there has been a lot of work, which I'll go on to describe in just a moment. There's also been influence through integration of mental health in high-level policy agendas, such as the United Nations policy brief on mental health and COVID-19, which I would encourage you all to take a look at. And also there has been leadership in how we are drawing together and bringing together best practices from the innovations that are taking place in mental health services all over the world. And that's through collaboration with the Mental Health Innovation Network, where there's a screenshot in the middle there of case studies that have been publicized. A big aspect of the work has also been the production of global goods. These are examples here of the work developed by the World Health Organization and the Interagency Group on Mental Health and Psychosocial Support. So these are technical tools to support governments and other organizations on their mental health activities, including risk communications, so communications for the public as well. So I think one of the more notable examples in here is a children's storybook, which was developed with inputs from over 1,000 children all over the world and their parents, and has since been translated in almost 100 languages, and within about 6 weeks became one of the most translating books in history, which we were not expecting, but that was very exciting. And next slide. Thank you. And also as part of the work that WHO engages in is of course country support. Now, where we would have engaged in field missions before, visiting countries, this is remote technical support. So this includes providing support for establishing the coordination structures to strengthen mental health and psychosocial capacity in countries, and also providing support for countries to adapt the tools that have been made available by WHO and the interagency group in order to implement it in their settings. So I will stop there. Thank you very much.
Thank you very much, Aiysha. I think you did an excellent job of setting the scene, and as we can all see, that it's a very complex picture, and I personally was very fond of the storybook that the World Health Organization jointly published, and I know that was definitely something that was of use to my infant siblings. Now, swiftly moving on to our next speaker, it is my next slide, please. It is my pleasure to introduce Priscilla, Dudhia, Policy Officer at Women for Refugee Women, a London-based charity that supports refugee women to tell their own stories and advocate for a humane asylum system in the UK. She focuses on researching the effects of enforced poverty on refugee women, influencing government policy, and coordinating Sisters Not Strangers, a nationwide movement of local organizations who are organizing to end destitution.
Thanks, Claudia, and thanks everyone who's watching today. As Aiysha sort of, pointed out briefly, women are particularly vulnerable right now, but I guess the purpose of my presentation today is to really highlight that asylum-seeking women, particularly those who've been refused asylum, are among those who are most at risk of deteriorating mental health during the pandemic. And that's essentially because of the intersection of factors such as gender, but also race and immigration status. Now, I felt like I couldn't really do this presentation without going back a bit and giving some background about the conditions that asylum-seeking women live in during ordinary times, if you will, so that you can really see how their vulnerability has exacerbated during the public health emergency. Now, I'm sure many of you already know this, but asylum-seeking people are effectively banned from working in the UK. And they have no recourse to public funds such as welfare benefits. They instead have to rely on, a separate and far less adequate system of support that was designed specifically with them in mind. Now, those who are in the system, who are waiting for an initial asylum decision or a decision on appeal, can apply to the Home Office for housing and financial assistance that equates to £37.75. That's been ever so slightly increased to an insulting £1.65 during the pandemic, but in ordinary times it's £37.75, and that amounts to about £5.39 a day. An amount that has to cover everything from food, soap and other toiletries, period pads if you're, if you're menstruating, phone credit, bus travel, the list goes on. And then for women who've been refused asylum, many of these are, don't have access to support. And essentially that's because the criteria to access support is extremely restricted. And that's worsened by a desperate lack of legal aid in the UK, which is particularly vital when, you're dealing with complex gender-related claims and where the woman has complex mental health needs. And so this, in sum, very few women kind of are able to access support at that stage after being refused. Now, there aren't any official figures on the number of asylum-seeking people who have been refused and who end up staying in the UK. The government doesn't bother collecting figures on them. But the British Red Cross said, I think it was a couple of years ago, that there were about 15,000 that were there. But that figure was based on the number of people that they were helping. So it's very likely that the true figure is much higher than that. So we're talking about thousands of people. If we just go on to the next slide, please. I just wanted to highlight the kind of, the different types of trauma that that's experienced by asylum-seeking women, the different stages where that trauma is experienced. Now, the first stage is obviously in the country of origin. Most women who come to the UK, I think it's safe to say, have fled some form of sexual or gender-based violence. That's certainly true of the women in our networks. About 78% had, in a recent piece of research we did, 78% had experienced, had fled a form of gender-based violence. So we're talking about things like female genital mutilation, forced marriage, honour-based violence, rape, sex trafficking, and other sexual abuse. Many of these women, sadly, suffer further violence and often further sexual violence as they make their way to safety to the host country. So again, in a recent piece of research we did, around half of the women who shared their stories with us had been re-traumatized. So they'd been raped again or sexually abused, tortured, detained or physically abused in another sense. So that's sort of a second level of trauma. Once they get to the UK, many women are then detained, in immigration detention centres such as Yarl's Wood that some of you might have heard about. Now, immigration detention can happen at any stage upon arrival. It can happen whilst the asylum claim is being processed. And it can, of course, happen once the claim has been refused. Now, even where conditions are reasonable, Detaining traumatized women can have horrifying, effects on their mental health. Again, a piece of research that we did showed that 1 in 5 women had tried to kill themselves whilst they were in immigration detention. It can cause flashbacks to past traumatic events and so on. It's hugely detrimental. So that's another bit of trauma. Then let's not forget the fact that, and as I was trying to outline in the beginning, that many of these women live in poverty. They're forced to survive on £5.39 a day, struggling every day, to meet very basic needs. And then they go through the asylum system. But as some of you will be aware, there's a huge culture of disbelief in the Home Office. Their practices have been shown to be racist, with many decision makers placing an incredibly high, almost impossible onus on asylum seeking people to prove that they deserve refuge. And then women, I would argue, are further disadvantaged by a system that's markedly sexist. Again, research has shown that decision makers often kind of lack an understanding of sexual and gender-based violence, how that affects a woman's ability to, retell her story in a clear and structured way, and also how that sort of violence falls within the UK's obligation to grant status. One woman told me when I was doing some research for a report that we published in February, I was so traumatized by this asylum system, I don't think my mental state will ever be the same again. And I think that's something that's not considered, the impact of not being believed when you've gone through so much. And then, finally, if you like, there's the trauma of enforced destitution. As I said, once you're refused, there's often no support, no right to work, and women are living in an extreme form of, in extreme poverty. And I'm sure many of you are wondering, well, why don't they go back? They don't return because, as I said, many of these women have gone through a very discriminatory system and feel that their stories of persecution were not heard and treated fairly. And so they still, rightly believe that if they were to return home, they would be persecuted. So they end up staying in the UK and living in destitution, often for years in this indefinite limbo. And as a result of that, many are sexually abused again. We found in this piece of research that I mentioned that was released in February that 1/3 of women who were sexually abused in their country of origin were sexually abused again in the UK after they were made destitute, which is incredibly shocking and unacceptable. And about 1/3 of those women tried to kill themselves after being made destitute. Yet for women who've experienced so much trauma, there are significant barriers to accessing mental health care, including NHS care. Many women are simply not aware of their entitlements. Women who have been refused asylum, often they're prevented from registering with their local GP because staff are unaware as well of entitlements. And then, of course, there's a very well-founded fear among many women with insecure status of being deported because, under the hostile environment, as some of you will know, there have been agreements between the NHS and the Home Office where data is shared among the two bodies. So, women are often too scared to seek help. And then, of course, there are, there's a very stretched NHS system with huge delays in service provision. A support worker that I spoke to last week actually said to me, and she's been working with asylum-seeking people for many years now, and she said that she had not come across an asylum-seeking woman who'd been successful in accessing therapy from the NHS, which is something I'm going to leave you with. And yeah, over a quarter of women that we spoke to recently had been unable to access healthcare. Yes, there are sort of charities and other specialist organisations around who are delivering really important treatment and specialist counselling for traumatised survivors of SGBV, but the demand is so high that the supply is sadly inadequate. If we can go on to the next slide. So now I'll just kind of touch on the specific effects of COVID-19 and the lockdown. So we've just completed some research as part of the Sisters Not Strangers Coalition. So that's basically 8 organisations who work with refugee women have come together to hear how women have been surviving during the pandemic, women who are living in England and Wales. Now, just to run you through some of the key findings, 3/4 went hungry. So these are women who are no longer able to, who are so reliant on visiting charities to access meals and small hardship payments that are vital, both for women who receive a grossly inadequate level of asylum support, but also the women who receive none. And we heard from women who were struggling to feed their small children. 1/5 were homeless, relying on community members moving from one house to another, and 1/5 were forced to share rooms with non-family members, such that self-isolation was impossible. The government has been recommended increased hand washing, yet over 1/3 of women had issues in consistently accessing water, soap and hygiene products during this time. And so, as women, were forced into hunger more than ever as they struggled to secure safe housing, inevitably mental health deteriorates, and the overwhelming majority said that their health had worsened, their mental health had worsened, with 1/4 saying that it had become much worse. About 70% of staff and volunteers who were supporting asylum-seeking women during the pandemic said that the women had experienced flashbacks. So Reem, one asylum-seeking woman from Cardiff, told me, past traumas and bad experiences came flooding back for many of us. Staying indoors all the time transported me instantly to Saudi Arabia, where I was not allowed to go outside. Now, drop-ins, as I said, that have been so vital in ordinary times to access meals and donations, are also really vital because they provide a safe space for women where women can, build friendships and regain their confidence. But of course, they're now closed. So women are feeling more isolated than ever. And this has basically put a strain on many of the groups in the Sisters Not Strangers Coalition who, including Women for Refugee Women, who simply don't have the resources or expertise to deal with an increasing number of women with complex mental health issues. That being said, I have to sort of say that many of the groups that we've been working with have been really imaginative and energetic in setting up virtual activities, like virtual drop-ins, basically, where women can join during lockdown. But as Aiysha also pointed out, digital exclusion is a huge issue. Many of the women had poor or no access to IT equipment. And so, and because of that, some of the most vulnerable women haven't been able to attend these. Same goes for some of the remote therapy that Aiysha was also talking about. At the same time, there have also been worsening barriers to accessing mental health care. Do I still have time to talk about that, Claudia?
I think we need to start wrapping up and moving on to the next.
Yeah, we can do that, exactly. And if anyone wants to know about how the pandemic has worsened access to NHS care, I'm happy to share. Thank you, and sorry for going over.
Thank you, Priscilla. Very insightful presentation. And I'm sure in the Q&A we'll have a lot of questions addressing the topic of your talk. It's now my pleasure to introduce Dr. Roopa Dhatt, a passionate advocate for gender equality in global health and the leading voice in the movement to correct the gender imbalance in global health leadership. Dr. Dhatt co-founded Women in Global Health in 2015 in an attempt to transform women leadership opportunities in health, and today they have more than 25,000 supporters in more than 90 countries and continue to grow. We are delighted to hear from you today, Roopa. The floor is yours.
Great. Thank you, Claudia. And really thank you to Young Leaders for Health for inviting me to this really valuable discussion. And it's, I think the panelists before have really set a great scene, talking very much about really just the gender aspects, but also the mental and psychosocial aspects that we are really seeing emerging during COVID-19. But we know from past pandemics, disease outbreaks, that these are not new issues. So really, I want to emphasize that as we learn from COVID-19, we should also reflect on the lessons learned from previous pandemics and really build back better. So today I'm going to be really focusing on the topic of recognizing women in health security and why it really matters. Next slide, please. So a bit about global health. For those of you that have been following the discussion on the gender gap in global health leadership, you'll know these numbers really well, but global health is delivered by women, led by men. When you take a look at the health and social workforce, 70% of that are women. But when you take a look at senior leadership roles, those numbers are down to about 25%. And if you look at the private sector, the numbers are even less than 5%. So clearly we have a existing structural challenge in global health where women are not being represented in decision-making and leadership roles. So this is the context that we entered the COVID-19 pandemic with. Next slide. And more importantly, when we go a step beyond looking at it just from a gender aspect, but really using an intersectionality lens, and in this case, really just focusing on representation from Global South and representation of people from lower middle income countries being in decision-making roles, what we can say is that women, especially from LMICs, are represented in less than 5% of senior leadership roles. And when you take a look at that number and contrast it to the fact that more than 80% of the world's population lives in the Global South, that is a very stark contrast. And so when we talk about leadership in women in global health, we're really committed to looking at power and privilege, challenging it for gender equity in health. Next slide. I also wanted to briefly share that women in global health specifically, we are a global movement. We are a platform for all voices, and we see ourselves really as a catalytic force and a strategic disruptor. We are a network of women and allies from all geographies and backgrounds, really fighting for equity in global health for all genders. Next slide. And our movement is spanned across the world. We currently have 20 chapters, and really encourage all of you that are joining in that as we talk about this topic, if it is of interest to you, please reach out to us and connect with our local chapters, but also the global movement. Next, please. And so specifically what Women in Global Health did when COVID-19 was really established as a not only a health emergency, but a pandemic in March, as we launched a campaign called COVID 50-50. And that really talks about how global health security depends on women. Next slide. And so in that campaign, we have 5 key areas that we're really focused on, and we felt that was critical that we, when we have a gender responsive approach to COVID, that it really includes these 5 aspects. So first for us is really around equal representation. Right now really is the time for women to be in leadership roles. The talent and expertise that women are gaining, what they are seeing at the front line needs to be part of decision making. And I'll be covering some of the data that we've been able to unpack around this. The second aspect is really around safe and decent work conditions. As we've heard in this panel already from other esteemed panelists, that there really is a increased mental and psychosocial toll that health workers are facing who are majority women. And some of the increased mental health aspects that have been expressed by women is, one, they are the ones that are being exposed a lot more to unsafe conditions. We know that physical protective equipment, or PPE, that was provided, especially early on in the pandemic, has been designed for male bodies and not female bodies, so not fitting women. We also know that many of the frontline community health workers today around the world do not have any PPE, yet they are going door to door to screen for COVID-19, providing other essential health services. So women, especially that are the health workers, not only are they getting exposed to unsafe work conditions, they also are having to make difficult decisions about whether or not to separate from families during this time, or to risk exposure of bringing COVID-19 back home, whether it is to their children or elderly. So there really is a lot of dimensions to the safe and decent work conditions that we are seeing, that women are not being at the decision-making table, are not really able to shape and design health systems in a way that accounts for the fact that women are really on a triple shift. They're providing health and social work, they're providing usually childcare and elderly care, or providing for their communities. And third, they have the added responsibility around COVID-19. So it's really about acknowledging that. The third aspect that we're really asking for, that it is critical that we recognize and value women's contributions, and that they receive fair pay, and especially fair pay when it comes to a lot of the social work and health work that they're providing. We know that women on average are provide almost 2 hours to 3 hours of household work on average a day, but that has been increased in COVID-19, especially with homeschooling. We know that women right now currently provide 50% of the work that they do in the health sector is currently unpaid, which is $1.3 trillion annually. So for us, it is very much that we need to compensate and not just have applause for health workers or applause volunteer work, but really ensure that as financial insecurities are growing in COVID-19, and the estimates from the World Bank are that there is anywhere between 70 to 100 million people that are going to enter extreme poverty, who will be majority women, that we really think about how do we create social protections and ensure that women are in the formal sector. And then the fourth part is really around gender responsive approaches. And for us, that includes closing the gender data gap. Early on in COVID-19, very few countries were disaggregating data at all by sex and gender. Very few are disaggregating it by health workforce infections. And so for us, a gender responsive approach is that health systems are designed in a way that they are both analyzing data and capturing data, both on a sex and gender aspect, but also looking at the different needs of men, women, and all genders. We know that harmful masculinities have an impact on why men are not necessarily accessing health services, are not engaging with some of the public health measures, including wearing masks, for example. So if we don't actually have a gender lens in our approach to COVID-19, we really will be missing out on having an appropriate response. And the fifth part of it is really well-funded organizations. We know that women's networks and organizations and movements really are the social protections in communities around the world. They are the ones that are really the safety net where universal health coverage does not exist. They create insurance pools, they share care responsibilities. And so right now, our funding architecture is not set up for funds to actually get into the hands of women, and especially women in social movements at grassroots. So our call is really to also allocate resources in a way that it gets to the hands of those that most need it, but also are really building the resilience in our health system and society. Next slide. So specifically related to the women's leadership aspect, we recognized early on that women, although make up majority of the health workforce and are part of many technical groups, are scientists, researchers, were not getting represented in the health security discussion. Some of our snapshot analysis through our colleagues showed that in the first month, media would only cite women 3-to-1 ratio versus men. So for every 3 men being cited, there would be women. And so it's really this like imbalance in representation from expertise. We also know that when we look at global task teams, women were underrepresented. Next slide. And so, and these numbers that we analyzed back in March was very much along the lines of showing that there were actually global task teams that came out that did not have any women. So the United States first coronavirus task team had 0 women, and then their number increased to including 2, so it stands still at 10%. When we looked at the WHO Emergency COVID-19 Committee, the very first one that was created, that was also around 20%. And we're in the process of finalizing a paper, which will be out in a couple weeks, that our our team has looked at over 90 countries around the world and their task team compositions, including task teams, which are scientific advisory groups and political decision-making groups. And the number is actually lower at almost 12%. Again, this is not finalized data, but really showing you that women's representation, even though they make up majority of the health workforce and they have the frontline expertise, but they also are technical experts and scientists, their representation is at a stark number of 12%. And what's been a part of the commitment around COVID 50-50 and Operation 50-50 has been really engaging member states and governments to improve these numbers. And we are really thrilled that at the last World Health Assembly this past May, the resolution on COVID-19 includes strong language around having gender responsive approaches, but also ensuring that women are included in all aspects of design, decision-making in the COVID-19 response. And that's something that I'd really like all of our webinar attendees that are tuning in to be aware of, that your governments have made those commitments to include that in COVID-19 action plans. And so it's really critical that we follow up at the national and subnational level and use the commitments they've made globally to ensure that women are represented equally. Next slide, please. And so why we really make this case for gender parity in decision-making, we know that gender inclusive and diverse decision-making is better health security. We consider this to have at least, 5 different dividends. There's a gender dividend, there's a health dividend, there's a development dividend, but we also know there is an innovation dividend and a knowledge dividend. So the more diverse the teams are, the better we understand problems, and the more likely we're going to have sustainable solutions and holistic solutions. And so it's not only the right thing to do, but the smart thing to do. It also leads to more effective and ethical responses. And this is critical to both addressing the pandemic, but also in the building back better. Next slide, please. So in closing, what I'd like to really emphasize is that global and local solidarity is really vital in this emergency, and movements like Women in Global Health and our partners really appreciate Young Leaders for Health for having this dialogue, really need to work beyond borders, and we need to keep confronting the global threat, but also really make sure that women are enabled as decision makers at all levels. We have global commitments. Now it's really about taking these global commitments and turning it into local action. And if you'd like to engage further with Women in Global Health, and especially our campaign around COVID 50-50, over the next 6 months, we are going to be working on those 5 asks. We're getting ready to launch our own series of action collabs next week, and we will be putting on events throughout the year, and really would love to be able to engage with all of you that are tuned in today. Thank you.
Excellent. Thank you so much, Roopa. I think what we can see from all our speakers now is that although women sort of are perceived to be, they are definitely proved to be a vulnerable population amongst the pandemic. There's great initiatives and to really elevate their voices, and they are sort of on the front line and really key in the response to COVID-19. We are short on time, so I'd like to move, next slide please, to move on promptly to introduce Alex Lanzetta, who is has worked with us over the past few months at Young Leaders for Health, and will allude further to the excellent article that she authored for us.
Hi everyone. I just want to say thank you to Young Leaders for Health for allowing me to talk about my article with you guys. So to start off, I just want to give a completely dumbfounding statistic. So 33% of the population of the United States is 33% of the population of the United States hospitalized due to coronavirus are Black, despite them only making up 18% of the community. This means that Blacks are almost twice as likely to be hospitalized for this disease than their demographics would indicate. And this ties into my article because I argue that the reason for this disproportional rate of African Americans getting this disease is due to systematic racism that is present in the United States. And before I go more in depth into my article, I just want to acknowledge that systematic racism does exist elsewhere outside of the United States, but for the purpose of my article, I just talk about the United States. So I talk about 2 main issues in my article that affect the health of the African American community. The first is food deserts. So food deserts is an urban area where there's no access to a grocery store. And this means that those living in these areas are forced to rely on convenience stores and fast food and other more unhealthy options as their main diet. And this results in higher rates of obesity, diabetes, and high blood pressure. And African Americans are also more likely to live in these areas. So only 8% of Blacks live in a census tract where there is a grocery store compared to 31% of whites. Another issue I talk about is how Blacks are less likely to have access to healthcare. So 9.7% of African Americans are uninsured in the United States. And there's also a huge other amount of African Americans who are underinsured, approximately 15 million people. This discourages African Americans from seeking medical care and makes it so illnesses go untreated for years and they get worse over time. And these two things these two aspects, food deserts and lack of insurance, leads to African Americans having higher rates of pre-existing conditions. And as we all know, those with pre-existing conditions are more likely to get either severely impacted by, if not die from coronavirus. And this helps explain the fact that they account for such a high percentage of those hospitalized, despite their population demographics not indicating that. Some of the pre-existing conditions that African Americans face due to food deserts and lack of health care are heart disease. So Blacks from the ages of 18 to 49 are 2 times more likely to die from heart disease, and they're also 50% more likely to have high blood pressure than their white counterparts. They're also more likely to die from stroke or diabetes. Additionally, while I don't speak about this in my article, I think it's important to bring up now. African Americans also make up a much larger portion of those who are working on the front lines and who are essential workers. So it is, they're also more likely to get exposed to this disease. So the combination of African Americans having less access to medical care, living in food deserts, and the fact that they're more exposed to coronavirus makes it so there's this huge disproportion. And this is all due to systematic racism in the United States. Blacks are consistently, historically and today, given second-class care. And the thing I want to end this brief synopsis with is the only way this unjust system is going to end is by educating oneself and others. The only way we're going to make it so people aren't needlessly dying due to the color of their skin in the 21st century is by supporting policy changes and reading about things like this or attending webinars like this so we can understand the inequalities people face in the country, and we can make the country and the world itself so we can make the world a more equitable place. And yeah, that's about it. If you want to learn more, go check out my article on YLH's website. Thank you.
Thank you very much, Alex. I'd encourage, as you highlighted, everyone to go and to read Alex's article, and we can definitely share that with all of you. On to the next slide. So now it is my pleasure to welcome Carley, who will, with Alex together, will facilitate the panel discussion amongst our speakers. And I know we have a lot of questions that have come in for our speakers. So it's over to you, Carley. Sorry, Carley, I think you're muted.
Sorry. Hello. Yeah, so we have a few questions already. A lot of them are directed at individual panelists, but please do jump in if you have anything to comment on. Our first question is directed at all of the panelists, and it asks, what has Corona changed about your perspective on mental health and its significance within the work that you do? If we want to start with Roopa and then go from there.
Great. Well, really what COVID-19 has shown is that mental health should not be an afterthought. It has reminded us that when we are facing a global pandemic, health security, that really to have both individual and health system resilience, we really need to make sure that the psychosocial and mental needs of everybody involved are addressed, so both from a patient perspective, but also from a provider and health workforce. So really, it should not be an afterthought, and those numbers showing how little investment goes into providing training and going to scale when it comes to having mental health providers. You know, that particular gap has been existing before COVID-19, and the needs are going to grow up after COVID-19 and during it. So we really should think about how do we invest in the health workforce so we're much more resilient in the Build Back Better.
Definitely. And Aiysha?
Thanks. Yeah, it's an interesting question for me, as I suppose I live and breathe mental health all the time. So if anything, what COVID-19 has exposed is the importance of mental health and always considering it alongside physical health conditions. And that it is not, I'm hoping that what is happening with this event is that mental health is no longer in the shadows, and it's demonstrating how relevant it is to every aspect of our lives, specifically from an almost whole of society or multi-sectoral approach. It's affected us at the economic level, at the work level, in our education, every aspect of our life. And I think what this has done is really highlighted to the public and to governments the importance of ensuring that mental health is part of the plans for other health conditions and even the response to COVID-19. Thank you.
And Priscilla.
Yeah, I don't have too much to add from what's already been said. I suppose for me, it's really kind of highlighted the full damaging potential of the existing policies that we have in the UK. You know, the asylum and the policies that make up the asylum and immigration system. It's really kind of highlighted how the persecution that women suffer isn't kind of understood adequately or listened to or cared about. And, you know, just the need for much greater investment, you know, in the NHS, but also for policies like the hostile environment to be completely scrapped, because it acts as a huge barrier to access for traumatized survivors of SGBV.
This is targeted at all of you that have just answered that question, but do you think, as you've all said, that it's highlighted these issues? That's kind of what COVID has done. It's highlighted the inequalities and the importance and presence of mental health at every level. Do you think, what can we do now to encourage the government to kind of act on these revelations? Like, how can we push for the government and policymakers to really act on this?
I don't mind going first. I mean, you know, as I was trying to highlight in my presentation, yes, of course, the women have come to the UK with, you know, having experienced horrific trauma from sexual and gender-based violence and so on. But that trauma has been exacerbated here, and they've been re-traumatized, and some of them have been sexually abused again after being, you know, forced into poverty or destitution. So I think, you know, the ask for me and for Women for Refugee Women and all the other organizations that I work with as part of Sisters Not Strangers is really to end inhumane policies that force women into poverty, that push them into abusive and exploitative situations that really damage their mental health and re-traumatize them.
Does anyone else have any comments on that?
Yeah, happy to dive into really how do we get, you know, act with government. So I think the first thing is really making sure that governments are making those commitments when there are global declarations, statements being negotiated. So that's one way a group like Young Leaders for Health can do, is providing position papers, informing the different member states that are engaged in G20, for example, the UN Security Council, the UNGA, the World Health Assembly, really, making sure that member states are informed with the positions that matter the most. So I think that's at the global level. But really, we know that global commitments only mean something if they are really translated into local action. So that's where national and subnational, looking out for what are the COVID-19 or the Build Back plans that are being designed, and being deliberate about reaching out to the public health agencies nationally and asking to see the plans, and asking for consultations, asking for public health consultations, and engaging with local media. Right now, it's unprecedented times where media is actually looking for health perspectives. I mean, Women in Global Health has constantly been approached to provide recommendations on who are women experts that can talk on a variety of topics. But what we're also asking our experts to do is not only talk about the issues, but bring a gender lens. And so that's one way that we're really advancing the gender agenda. So really encourage all of you to take advantage of the fact that right now health is on the minds of everybody, especially head of governments, and to really drive local action, local engagement. And that could be even with your city-based public health response.
And if I've got time to just jump in as well, I'm not going to repeat the brilliant points that Priscilla and Roopa just made, but to add to that, I just want everyone to bear in mind that on average, governments only spend about 2% of their health budget on mental health. And that's not enough. And that's not sufficient, especially now that COVID-19 is raising the extent of work that needs to go into addressing the mental health needs of the population. So I want you to hold that in mind as part of advocacy, because this requires action from all stakeholders in this area. And the one thing that I might add on top of the points that were made is research and data. That this is a very important component of producing the evidence and the information that is needed to drive action as well. So research and data for mental health.
Perfect, thank you. Alex, if you'd like to finish up and all.
Yes, so I just want to say thank you to everyone who spoke today, and I would like to ask every panelist, just what their main takeaways from what they stated today in their discussions, and just a few words, so we can all go away knowing like the main points of what you want everyone to get. And whoever wants to start first can go first.
I will be brief. I think the main points from the World Health Organization is that mental health is a crucial part of the response and recovery for COVID-19, that it needs to be integrated, that the whole of society approach is needed, and that there are populations who we really have to pay special attention to. One of those is women. Thank you.
I can go next. So message really simple from Women in Global Health. COVID-19 has disrupted business as usual on a global scale. It really does give us an opportunity to reimagine the future, to really build back better. We don't see this as a gender war. When we really advocate for gender equality, we really need to make sure that the message is clear. Gender equality is everybody's business, and it results in health systems that can provide for all genders. We only have one health system. Women want to be enabled to deliver better health for everyone. In return, all of society really gains the triple gender dividend, a health, gender, and economic benefits for all of us.
I'll be super brief, really, just to kind of emphasize what I've already said. There's a real opportunity here to build back better, to build a more, equal, caring, and connected society is a sort of language that we're using. As I say, a lot of, the women that we work with, these are women who are incredibly vulnerable during ordinary times, who are now being made even more vulnerable. And nobody's, ability to get through this crisis should be determined by their immigration status. So for me, and I hope for the people listening, it should really highlight the need for everybody, no matter, whatever your gender, whatever your race, whatever your immigration status, to have access to sufficient income, to have access to secure housing and safety. If we fix those things, we can go, that's some way towards, increasing the well-being of some very vulnerable women that we work with.
Thank you all for your key takeaway messages. I'm aware that we're over time, but I hope that those takeaway messages really sort of stick with our attendees. And I think definitely we could talk about this issue for a lot longer. And I think there's a lot of concrete positive solutions and ways that we can build back better together as a society. If anyone still has any questions, please, next slide please. Please do not hesitate to contact us at Young Leaders for Health on the email shown on the screen. We will try and get any of the remaining, we will monitor sort of the Q&A and chat box and revisit it and try and answer as many questions as possible, and sort of disseminate further information on our website. We will be also sharing this PDF, and this webinar is recorded, so it will be available on our YouTube channel. The second webinar of the series will take place in 2 weeks on the 23rd of July. So I hope to see many of you there, and we'll be addressing the implications of the pandemic on the wider universal health coverage agenda and attainment of the SDGs. So I think this first session was an excellent in sort of setting the stage, and I hope you can join us for that. And I hope you enjoyed it as much as I did, and I hope, we look forward to reconvening very soon.